So I'd like to welcome Nolte, editor for the book of Person-Centered Health System that the European Observatory of Health System and Policies have produced together with Vårdanalys, and that the Vårdanalys report is based on. The book is called Achieving Person-Centered Health Systems, Evidence, Strategies and Challenges, and will be published next year, at spring, I hope. Ellen is today Professor on Health Services and System Research at London School of Hygiene and Tropical Medicine. So Ellen, please, the floor is yours.
Thank you very much indeed for having me here today and giving me the opportunity to present this work, which is really the output of very many people who I'm going to show at the end of this presentation. In particular, I'm not the only editor, so Anders Sanel is a co-editor together with Sherry Mercour. And Anders has been a huge inspiration in developing this work and very patient when I came up with yet another idea. So what I'm going to do today is really to flick briefly through the background to this work. And if I've understood correctly my preceding speeches, it is, there's a lot of confusion still about the terminology. So I wanted to say a little bit more about that before coming on to the study, where I'm really going to focus on what we were focusing on and share some of the key insights, but also not only saying, you know, it's very complex, but also suggesting ways forward where we might want to focus on to really push systems to becoming more person-centered. Now, of course, person-centeredness is a big policy topic everywhere. It's actually becoming globally way more important. The most recent incarnation, if you like, is the OECD Health Minister Statement, which was issued in January last year, vocalizing or expressing the view that health systems have to become much more people-centered. The whole idea, of course, isn't particularly new. It can at least be traced back to the Alma Ata meeting on primary care in 1978, which had its 40th anniversary this year, which explicitly stated that the people have the right and duty to participate individually and collectively in the planning and implementation of their healthcare. Now, this statement is 40 years old. And one of the challenges that has been emerging since, or has been grappling systems, is how do we actually operationalize that? And one of the challenges, I think, is around what do we mean by the term involving, by the term centeredness. And I'm sorry, I meant to animate this a little bit more, but bear with me for the moment. I know there's lots of words here, but I think one of the challenges here is there are patient-centered, user-centered, family-centered, people-centered, and then there's personalized care. And the question is, well, there are different terms used. Does it make a difference? In principle, it shouldn't. In practice, it does, because it very much reflects the perspective we are taking and whether we want, or if we want to move to more centered systems. And I think the problem is also because there is so much variation in the terminology used, there's really a lack of clarity about the strategies that are really available, but they're also effective in helping services and strategies become more person-centered. But also I think there's a fundamental, not disagreement necessarily, but there are different perspectives about what centeredness, I should just say for the moment, actually should achieve. So there is perhaps a more narrow view which sees centeredness as just another dimension of quality of care, which is fine, or it sees it more like a broader idea of engaging patients and their carer in the health and healthcare, or which sees person-centeredness as a fundamental design strategy and how we want to organize our health systems. And of course, each of these perspectives is legitimate, but each of these has different implications on how we're going to achieve what we want to get out of it. So when we've done this work, what we notice is a lot of there's a lot of rhetoric around centeredness. And what we often find is actually reduced to better access to information for people who use services, which is fine, but it's only one of the very many facets of centeredness. And here this is taken from the OECD ministerial statement I've mentioned earlier. And I think the first bullet really encapsulates some of the many challenges, namely that it might be all about increased access to more information of health, about health, which then broadens the range of possible ways for people to manage their own health. Which is one aspect of it, but it's by no means, and many of you in the audience will agree, it's by no means what person-centeredness should be limited to. There's also the issue about centeredness, involvement, participation, empowerment, and often these are used as if they were the same. They may be the same, again, depends on who you ask, but I think empowerment is a particularly challenging one because it's used very, very broadly, and often if you ask what do you really mean, people don't say, well, it could be this and that and the other. And again, we have this sort of a broad idea of it's about the autonomy of the individual and self-determination, or it means, well, it's kind of a way that we enable people as they go through healthcare to take more charge of their own care, or it is also equally seen quite often, it's an intervention simply to help people to self-manage better. And again, I think these are all legitimate, but if we look about strategies and which are effective, we have to kind of think through what is it we have in mind. And similar issues can be said about patient participation. I think fundamentally, all of these concepts I've just mentioned have some commonality, and this has been phrased in the literature as the philosophical argument and the performance-based argument. I'm going to come back to that a little bit more, a little bit later. So the philosophical or the democratic argument simply says, actually, individuals should have more say in their own care. It's a right, and it's an intrinsic value, and that's why we have to pursue it. But there's also the performance-based argument, which essentially argues if we only had better informed patient, you have the informed service user, they go out, choose the right providers, and the providers behave better, and as a result, provider and service performance increases and we reduce costs. That's another way of looking at it, and I'm going to come back to that in a moment. That's, I think, where many of the challenges lie that contemporary systems are facing, but also actually the evidence that person-focused care will achieve any of this still remains rather patchy. And this is where our study comes in. As was said before, it was led by the observatory together with Vardana Luce. This is a kind of mock-up draft. It's not going to look like when it's eventually going to come out. But what we really try to do in this work is to provide policymakers, not as a prime target audience, but because they are the ones who essentially have to move on to this, with the evidence on the range of strategies that may be effective to achieve more person-centered health systems. And we did that through taking particular different perspectives from the patient as a service. Here's something wrong. Oh, sorry. Is it better? Sorry. So we looked at it from, apologize. We looked at it from the the different roles people really take in the health service as an individual service user, as a citizen, as a taxpayer, as a care manager. And I think some of the more sobering insights here, we find really that existing models and strategies essentially don't really deliver yet on what we would consider involving the public voice systematically. And this is where we believe systems really have to work towards still. So what we used a very pragmatic way of thinking about this study, and we used this particular framework, which was developed by Dent and Pahor in a different study, which we felt was quite useful just to frame the work we wanted to do. So thinking about voice, people, being involved in decision-making at the various tiers of the system, choice, the person as a consumer of healthcare, and a more novel concept or new concept, emerging concept of co-production, which which kind of assumes that people are involved in the actual delivery of their own care. And of course, these three facets are the facets of the same issue we are talking about. So there's no clear-cut distinction. But for us, it was quite useful to then look at what we wanted to explore further. So engaging in health service and system development and research, evaluating the quality of health service and system, which Angela will talk about in more depth later on, making decisions about purchasers or providers, and participation in their own care, such as shared decision-making and self-management. And for each of the perspectives, we looked at what is the underlying, why would you want to do it, what is being expressed as the underlying rationale, how do we know things work, and if things work, why are they not being implemented? And also what are novel approaches and the policy lessons learned. So what did we find? Oh, sorry, it's been cut off. What we find was one of the key issues is that there are different drivers to person-centeredness that have emerged over the last 40 years or so, which have very different ideas and are also sometimes contradictory. And it's because of this contradiction that we find that systems perhaps achieve less than they could. So one driver is really the kind of social movements of the 60s and 70s. It's all about self-determination, it's all about autonomy, pretty much driven by the disability movement at that time, that, service users and providers should have equal power in determining what is happening to their own lives. In parallel, perhaps, is the recognition of a democratic deficit in public services, the idea of deliberative democracy, and that people who are paying for services should actually have the right and also the obligation to participate in the delivery of those services. And coming back to this idea that involvement is an intrinsic value in itself. And the third one is what I've mentioned earlier, the performance-based argument, which we really can trace back to the neoliberal policies of the 1980s, the idea that we have to bring more market into healthcare, and really the production of the informed service users who then goes out shopping for the right services and then produces a high-performance system with reduced cost and improved efficiency. So these are the kind of streams, and when we looked at the evidence that is presented in the book, what we find really is actually that the performance-based perspective is really the one which has driven a lot of person-centered strategies. And the challenge of that is that it's largely driven by the perspectives really of providers, professionals and policymakers, and less so by the people who these services are being targeted at. And this might explain why the evidence base is still pretty inconsistent. So what we do find, yes, there is evidence. There is evidence that some strategies impact positively on some anticipated outcomes for some populations in some settings, which is fine, but it doesn't really underpin a systematic approach to achieving person-centered systems. What we do find, perhaps not surprisingly, given that much of this has been focusing on producing the informed service user, that the evidence tends to be much stronger for individual level approaches, such as shared decision-making or self-management support. And what we would venture to say is a more narrow perspective of person-centeredness, sort of supporting the individual in participating in decisions, in making the right choices, and in helping themselves, if you like, by supporting self-management. There's much less evidence, or solid evidence, I should say, on involving people at the more broader level in kind of healthcare design, in service delivery, or in health policy decision-making more broadly. And one of the challenges, again, is also that especially the more broader policy, they often lack an underlying theory, how does this particular strategy actually going to deliver on a particular outcome? So we often find strategies that are based on, it sounds good, let's do it. But the actual mechanism by which a particular outcome should be produced is often quite unclear. And there is really a need for rigorous evaluation that really thinks about, okay, what is the context within which this particular intervention or strategy is being delivered, and really also to think about the implications for equality and diversity. And I'm going to come back to that in a moment. So, especially what we find, what I've said just before, is that evaluations are lacking, or maybe the evidence isn't very robust. It's also because many of these policy instruments we are using might actually not be effective in achieving what we want to achieve. And one good example is choice policies. So choosing providers, choosing insurers, choosing payers, not necessarily choosing treatments. It's a slightly different debate, I would argue. But choice policies have really been introduced to improve efficiency of the system, and the evidence is pretty lacking so far. There's some really interesting evidence around personal budgets, so allocating individuals and their carer a budget to go out and buy the services they think are most appropriate to themselves, and there are different ways of doing that. And it's interesting when you look at the evidence, the impact on costs and value for money is very difficult, but actually it may improve control, well-being and quality of life. And then the question for policymakers is, okay, what do we value more? Do we really value cost reduction, or actually we might think this is important enough of a goal, and further down the line it might help us to save costs as well. But because of the lack of the evidence, or the consistency of evidence, is that we don't really, it kind of impedes on the wider rollout of those strategies that are actually effective. And as I said earlier, I think this is one of the fundamental challenges we are facing, that much of the evidence we have and much of the strategies are really driven from a professional perspective, a policymaker, manager perspective. And it's still pretty much void of individual voices that are being heard systematically, and we see that throughout the evidence. In some areas more so than others, but this is some of the key challenges we find. So of course I don't want to talk only about challenges and how bad it all is. I also want to say a little bit about how can we move forward. And in our study this is some of the areas we suggest for further exploration, of by no means exhaustive. This is just the beginning, what we believe is a much longer process. And I just want to run through some of these. So firstly, it's really about strengthening and enabling capabilities of people at the different tiers of the system. And many of you will be aware of the concept of health literacy as seen as a key lever to somehow improve outcomes. And it's an interesting concept, but when we look at the evidence, a lot of this focuses on we have to educate the individual as a service user. It neglects that we actually also have to educate, if you like, the professional provider, the manager, the policymaker. All of them are part of the system and require health literacy. But what I found quite staggering, and I might have missed something in looking at the evidence, there's a lot of conceptualization what health literacy is supposed to mean, where it comes from. But very few, actually I found none of the definitions that actually did check with the public what it means to them. So what do people, you, us as service users, as professionals, as anyone, think about the idea of health literacy? And of course, if we don't really understand what people think about it, it's perhaps a little bit, it's not surprising that some of these approaches don't work, because they kind of try to target different things. There is more recognition about that providers, professionals, policymakers, managers also need to become more health literate, with recent concepts such as health literate organizations and organizational health literacy responsiveness. It's a very long term, which has been developed in Australia, which looks at, okay, how can organizations, healthcare organizations, become more health literate? And by health literate, they do mean the manager, the working environment, the policies they implement, the way they train their providers. So not only focusing on the patient as a service user. The second lever we've looked at is digital technologies. And what we observed again, that digital is often claimed to be the main route into strengthening person-centeredness. And I would add perhaps too often, because again, the evidence isn't particularly good. And I think one of the key challenges when you think about contemporary health systems, the contemporary burden of disease, is that there is a continued digital divide, and people talk about the primary, the secondary, and the tertiary divide, accessing it in the first place, using it, and comprehending it. And these are just some figures from European Union citizens from 2015 looking at regular internet use. And we can see, yes, it is increasing, but we still see quite substantial divisions by educational background and also by age. And this matters because those who are least likely to actually use those technologies are the ones who are most vulnerable in terms of health risks and chronic illness. They are the ones who should actually benefit most. So e-health strategies really could exacerbate or deepen existing social inequalities if they are not taking account of these sort of issues. And e-health strategies, the rollout, is a notorious difficult issue, and countries are continuously facing challenges. This is just some stuff which comes out from a recent review by Ross et al. That identified some of the key promoting factors. I'm not going to go through all of these, but it again highlights that we really have to take a systematic approach of thinking about it. Who's going to benefit? What do we need to consider? Who's going to be involved? Finally, I think there is this issue about, or a lever is to strengthen and enable the redesign of services at the different tiers. And I'm not going to talk about this because you're going to hear about it after lunch from Angela, but this is one of the key issues which we really need to push forward on if we wanted to really inform person-centered system design. Do we still have time? Okay. Another aspect of that is the systematic investment in education and training. And education and training here is really about providers, professionals, managers, policymakers. Because thinking about person-centeredness does really require a very different sorts of competencies and skills and knowledge for the various people involved in service design and delivery. And I think we still don't quite understand on how to develop the workforce to put person-centered approaches into practice. And when we did our review on self-management support, it was really interesting to see some of the studies that looked at physicians in particular who voiced things like, well, I realize I just have to shut up and listen, which is often quite difficult, certainly in systems where the consultation is limited to 10 minutes. And, you have to go through so many different things. But also, again, for physicians in particular, you actually have to give up a little bit about your own expertise and to take into account, okay, what is the expertise of the patient and whose expertise counts? And this is particularly challenging or particularly important for chronic conditions where patients have just so much more information that needs to be shared and which physicians or providers need to understand in order to devise effective plans. But it's not only the physician, so you as a GP in a practice might be very aware of wanting to shut up and listen. But, the context within which you are working might not allow you to do so for various reasons. So the organization or the managers of organization also need to consider how they support people to deliver more person-centered services. And I think in particular in in countries, or in all countries really, of course, organizational priorities are very much reflective of the local context, and they may often contradict national priorities. So how can you, as a manager of an organization, overcome the often contradictory forces and pressures, which is quite challenging? There also, I think the wider policy framework doesn't really often take account of the local problems or challenges organizations are facing. What we often see is new policies are being developed at national level, which are all sounding very great. But, it's the people on the ground who have to implement them, which means they need support. And support, I don't necessarily mean funding. It means time, it means training, it means thinking about changing behavior, which again takes time. Then healthcare redesign is, of course, very important overall. And what we find is that much of the evidence on person-centeredness, as I've mentioned earlier, focuses on the interpersonal level between the care provider and the individual service user. And of course, we have to think broader than that. There have been a number of studies which looked at levers for the implementation of person-centered care at the organizational level. And I've just listed these here, although I have to admit, these are pretty much the key levers for any system innovation. It's not necessarily limited to person-centered care. It's a commitment of senior leadership, engaging of staff at the different levels and the service users, the systematic measurement of feedback, a culture of supportive change, and the policy framework. Now, incentives are used quite widely to get especially physicians to do what you want them to do. And that's fine. The challenge is, of course, how they link up. And what we see, for example, in England or in the UK more broadly, that a lot of the incentives are linked to biomedical or clinical outcomes, such as, your blood pressure, blood sugar levels, etc. And if your focus is on achieving those, you are less likely to actually spend an hour talking to your patient. Partly you don't have time anyways, but also it's not rewarded. So you do focus on those things where you're being paid for, and this may be counterproductive. And I've mentioned already that adequate resourcing is key, and resourcing I not only mean funding, I mean training, support, time, etc. But also, I think there needs to be a systematic approach, or we think there needs to be a systematic approach of exploration, evaluation, and organizational learning. So seeing the organization as a learning system and not as static. You implement something and hoping it's going to work. So what have we learned overall? Person-centeredness has become a key priority, as I've shown. We find there's a wealth of experience really across European countries become more person-centered, but what we find is that many of these strategies are not very joined up. It's fragmentation, different perspectives are acting at different levels. But I think the most important finding really is the people who this is all about are pretty much lacking in many of these developments. So the public voice still pretty much remains absent in many of the local strategies are being considered. And I think, we really believe this is a fundamental shortcoming. And if policymakers are really serious about achieving person-centeredness, this is one of the first things that need to be addressed. I should just add, before I close, an anecdote. I went to a meeting of policymakers in Brussels recently where we talked about priorities of future health services research. And then the typical things come up: care integration, workforce inequalities. And then someone mentioned, and the patient? Oh yeah, of course, patients, they have to be somewhere there as well. So it actually isn't in the mind of the people who make decisions as yet. It's always like it's an add-on rather than a systematic partner in the process. And because I started with Alma Ata, I just wanted to end with the most recent declaration of Astana on primary healthcare, which I think perhaps leads us at least some way towards what we've talked about today. So to support the involvement of individuals, families, communities through their participation in the development and implementation of policies and plans that have an impact on health, to promote health literacy. Okay, I think here they need to work on a little bit more to satisfy the expectations of individuals and communities, to supporting people. And people here, we would argue, has to be broader than just the service user. It has to involve the providers, the policymakers, the managers, and to increase community ownership. And finally, as I said before, this study wouldn't really have been possible without the collaboration and incredible patience of many of the people who've contributed to this work, foremost Anders, I've already mentioned, all the authors of the various chapters in the book, in particular the participants of a roundtable we held here in Sweden last year. Those inputs have been extremely valuable in shaping our work. And the very many people who read the stuff and gave us further guidance on how to involve it further. And of course, the team at Analyse, who have been super, super patient. And I would like to thank you for that and for your attention.
Yeah. Thank you, Ellen, for this interesting presentation. I think we can go out here so the cameras will see us. And we will now open up the floor for questions from the audience. But meanwhile, when you are like thinking, how should I say this? I can take one question for starters.
Okay.
The book describes the knowledge that exists concerning numbers of different strategies and methods that can contribute to more person-centered care. But if there is one thing, you just have to choose one thing from this presentation or book, of course, that you would like the audience here to take with them back.
I think the fundamental one is what actually Angela is going to talk about. We have to ask people what they want from care, and we don't understand that. I mean, a lot of the interventions, the strategies are driven by what policymakers, providers, professionals think the patient wants, but we actually don't know what they want. So, before we started, I spoke to someone here. There's this really interesting study which looked at self-management support in particular, and they looked at what service user and their carers expect, and they focus on physicians. And as you could expect, there was no overlap between those. So if we are constantly looking at different expectations, even at the individual service level, we're not going to go anywhere. So we really need to understand: do people want? To what degree do people want to be involved? I think shared decision making is perhaps the most evaluated aspect of that. But in other areas we still don't understand it. And the other area, is it one full done? I'm not allowed one more?
Okay, sure. One more, it's okay.
And the other one, I think, is it assumes the rational patient, that they, you have the information, you go out and act upon it. But for people, especially with multiple conditions, health services is just another burden to all the other things you have to do. So we have to design systems which make it easy for people to function. And I think to function, however you decide you want to function. And I think this is a particular challenge for people who live in very challenging conditions, who don't have the means, physical, mental, or support means. They live in very deprived areas, so you have diabetes, you ought to be going out, but actually your area is very, very unsafe, so you'd rather not go out. So, how do we incorporate that into support systems?
Two things. Okay, we keep them. We take them back to our workplaces. Good. Do we have any questions from the audience? Sarah.
Thank you for an extremely interesting presentation and a very looking forward to reading the full report, even though I've seen part of it before. So there's so much to digest here, but I want to focus on the part you said about e-health.
Yeah.
Partly because Sweden has a very ambitious e-health policy. So you said that e-health can exacerbate social injustices. And Sweden, with our very high internet use, probably has less of that challenge, I would say. But at the same time, we know from studies that people with chronic diseases are more online and search more and probably are better at using e-health. Do you think that could be a leverage to use for this?
Yes, should I answer now? Yeah. No, I absolutely think e-health is a very important lever. But I think what happens at the moment is that e-health is sort of just given out, and it's expected that people pick it up and use it, and which is fine for people who can and have the willingness and ability to use it. But I think we have to think more carefully about those among us who are less able to use those technologies for all sorts of reasons. And I think one area which concerns me a little bit is there's a lot of work on supporting people with cognitive decline. But of course, cognitive decline and e-health, digital device use can be contradictory. So, how do we optimize those types of systems? And there's a lovely study by Trish Greenhalgh and others where they've evaluated a number of digital technologies. And one included, when you are at home and there's an emergency, and then you kind of switch the button and then the
alarm button.
Yeah, the alarm button.
Yeah.
And they found in this qualitative study there were a few people who had that device and still didn't call the ambulance because they're like, oh no, it's going to go away. I don't want to bother anybody. So yeah, the device is available. People know how to use it, and yet they don't use it for all sorts of reasons. I think we have to understand much better how people relate to these sort of sort of facilities, instruments, tools.
Thank you for highlighting the importance of the user perspective there as well. Thank you very much.
And Sarah, who are you?
I'm Sarah Rigger. I'm a doctoral student at Karolinska Institute, and I'm a project manager for the project Lead Patients och Spetspatienter.
Perfect. I forgot to ask you to say your name and where you're from before you ask your question. We had another question up here. Or did you change your mind? Okay, over here. Kajsa, how's it looking on Twitter? No, nothing? Come on, people. We have to be more active on Twitter.
There was a lot of stuff in there, I agree.
But I have one more question then. In your work with the report, have you come across a specific country that you think that the Swedish system can learn from?
Oh dear, cross-country learning is a challenge. I think I wouldn't single out a country which is doing well on everything. I think lots of countries have experience with some bits where we should be looking at. I can recommend, if I may, a recent report authored by Angela on shared decision-making, where you looked at various countries in Europe, how they've implemented policies around that. Shared decision-making is an interesting area because, as I said before, there is quite a lot of stuff going on. There's a lot of work going on, and countries are moving further and further also as part of national legislation into that field. And I think there is quite a bit to learn from how we can perhaps look at other countries' experiences. And then, of course, there is a lot of local experience as well. So the country I know perhaps best at the moment is England. There's a lot of local, very innovative work going on around community participation, about community workers supporting patients in GP practices and to help them to use care in a different way. So I think there are lots of local experience, but I wouldn't want to single out necessarily a country which has kind of cracked it, because I don't think it has. I don't know, Angela, whether you have a different view.
I think there are lots of great examples, but
Yeah.
And Angela agrees, if anybody didn't hear it. And yeah, you can take that later. But she's agreeing to this. Any questions? Okay, then I have something here for you to thank you for your time. It's a Swedish cutting board, Swedish design. There's no meaning in this that we should cut something. It's just a nice piece and a memory from your time here.
Thank you so much.
Thank you so much.
Very kind. Thank you.
And
thanks.
good luck with the report.
Thank you.